invited guests are requested to sit back.
Hadirin dimohon duduk kembali. Excellencies, participants, ladies and gentlemen, we are now going to listen to the report of the committee of the Second International Conference on Midwifery and Health Science 2022. Ladies and gentlemen, please welcome Mrs. Yusni Podungge, M.Kes. PM. Thank you, Mrs. Yusni Podungge. Ladies and gentlemen, now we are going to listen to the welcoming speech delivered by Director of Gorontalo Health Polytechnic. Ladies and gentlemen, please welcome Mr. Muhammad Anas Anasiru, PM.
We are now continuing our meeting to the next agenda, that is to hear the keynote speech will be delivered by Director General of Health Workers, Ministry of Health of the Republic of Indonesia, each represented by Secretary Director General of Health Workers. Ladies and gentlemen, please welcome Mr. Sugianto, SKMM SCPH. PM. Thank you, Mr. Sugianto. For the success of this morning activity, let's listen to the prayer that will be read by Mrs. Nur Inaya Adam, SST. PM.
Playing Song of Mars of the Gorontalo Health Polytechnic.
Lanjut, Panto. Panto, lanjut. Masih ada. Ladies and gentlemen, may I have your attention please? The opening ceremony is going to start in 5 minutes. Please have a nice seat and please be active the camera in Zoom meeting. Thank you.
Excellencies, participants, ladies and gentlemen, Assalamualaikum warahmatullahi wabarakatuh. Peace be upon you. Good morning, and we are happy to welcome in the opening ceremony of the Second International Conference on Midwifery and Health Science 2022, held by the Department of Midwifery, Health Polytechnic of the Ministry of Health, Gorontalo.
The Honorable Director General of Health Workers, Ministry of Health of the Republic of Indonesia, each presenter by Secretary Director General of Health Workers, Mr. Sugianto SKM MSCPH. The Honorable Director of Health Polytechnic Ministry of Health Gorontalo, Mr. Muhammad Anas Anasiru SKM M.Kes.
The Honorable, the All International Seminar Speakers, Dr. Nisha Clement, Associate Professor from ESIC College of Nursing, Bangalore, India. Dr. Maria Cristina Ramajo from Arellano University, Filipina. Dr. Ribeka Horiguchi, Associate from Otemae University, Japan. Dr. Tjokorda Dalem Pemayun SpPD-KEMD Finasim from Department of Internal Medicine, Faculty of Medicine, Diponegoro University, Indonesia. And the last, Dr. Nurjasmi M.Kes from Indonesia Midwife Association, Indonesia.
The Honorable Head of the Midwifery Department of the Gorontalo Health Polytechnic, Mrs. Rabia Jakaria SKM M.Kes. The Honorable invited guests and participants of the Second International Conference on Midwifery and Health Science 2022.
After the success of the ICMHS activity last year, in 2022, Midwifery Department of Gorontalo Health Polytechnic carried out this activity with the theme, Optimizing Midwifery Service to Prevent Non-Communicable Disease in the Reproductive Cycle, which will be held for 2 days, started today and will end tomorrow.
This conference provides a great opportunity for potential participants to share the latest theoretical knowledge, research findings, and their experiences in dealing with issues and developments related to midwifery and sustainable information. As such, the conference will feature presentations by international speakers, which are the topic of the current session.
Dear invite guys, with me, Ahmad Fahmi Swaiba, and my partner Nancy Oli will guide the event in the morning.
Ladies and gentlemen, by saying Basmalah, Bismillahirrahmanirrahim, the opening ceremony of the Second International Conference on Midwifery and Health Science 2022 in Friday, July 22, 2022 is started. Singing the Indonesia Raya Anthem, invited guests and all of participants are asked to stand up.
Hadirin dimohon berdiri.
invited guests are requested to sit back.
Hadirin dimohon duduk kembali. Excellencies, participants, ladies and gentlemen, we are now going to listen to the report of the committee of the Second International Conference on Midwifery and Health Science 2022. Ladies and gentlemen, please welcome Mrs. Yusni Podungge, M.Kes.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam.
Good morning, ladies and gentlemen. The Honorable Director General of Health Workers, Ministry of Health of the Republic Indonesia, is represented by Secretary of Directorate General of Health Workers, Mr. Sugianto, MSCPH, Director of Health Polytechnic Ministry of Health Gorontalo, Mr. Muhammad Anas Anasiru, SKM M.Kes, Vice Directors of Gorontalo Health Polytechnic, Head of Subdivision of General and Academic Administration Gorontalo Health Polytechnic, Head of Midwifery Department, Mrs. Rabia Jakaria, SKM STKP M.Kes, the ranks of Academic Community of Gorontalo Health Polytechnic, the Chairman of Indonesian Midwife Association for Gorontalo Province, the Head of Alumni Association of Gorontalo Health Polytechnic, all the invited speaker, invited guests, and participants of the conference. I am Yusni Podungge, the Chairman of Committee of the Second International Conference on Midwifery and Health Sciences 2022. First of all, I would like to say Alhamdulillah, because in this morning we can gather in this wonderful academic forum. Before we get started, I would like to express my pride and my appreciation for the hard work of the entry committee, all the parties who have support, and the participants, so that this event can be carried out and hopefully it will run smoothly and provide many benefits. In this chance, allow me, the Chairman of Committee the Second International Conference on Midwife and Health Sciences 2022, to present report on something of this event. This event is named the Second International Conference on Midwifery and Health Sciences 2022, raising the theme, Optimizing Midwifery Service to Prevent Non-Communicable Disease in the Reproductive Cycle. Implementation of this event is based on the decree of the Director of Gorontalo Health Polytechnic with the Midwifery Department of Health Polytechnic of Gorontalo as host and Indonesian Midwife Association in Gorontalo as co-host of this event. The purpose of this event is providing conference participants with knowledge on the prevention of non-communicable disease in the reproductive cycle as a means of scientific communication for students, healthcare provider, research, academic, and policymaker. Build partnership with the health professional and research from different countries in health development effort. The speaker of this conference come from 5 different countries and institutions in some region worldwide, include Dr. Nisha Clement, Associate Professor from ESIC College of Nursing, Bangalore, India, Dr. Maria Cristina Ramajo from Arellano University, Philippines, Ribeka Horiguchi, Associate from Otemae University, Japan, Dr. Tjokorda Gede Dalem Pemayun, SpPD-KEMD Finasim, Head of Endocrine Division, Department of International Medicine, Faculty Medicine UNDIP, RSUP Hospital Dr. Kariadi, Semarang, Dr. Nurjasmi, M.Kes, Head of Indonesian Midwife Association. The participant of this conference is 700 conference, 69 teams oral presentation, and 32 team of poster. Time and place. This international conference is held on 22 and 23 of July 2022, conducted virtually using Zoom meeting and broadcast on YouTube of Midwifery Department Health Polytechnic of Gorontalo. Method, plenary lectures and discussion with speaker. Source of fund, This event is financed from the DIPA funding Health Polytechnic of Gorontalo 2022. Thank you very much and congratulations on participating in this national conference. Wassalamualaikum warahmatullahi wabarakatuh.
Thank you, Mrs. Yusni Pudungge, M.Kes. Ladies and gentlemen, now we are going to listen to the welcoming speech delivered by the Director of Gorontalo Health Polytechnic. Ladies and gentlemen, please welcome Mr. Muhammad Anas Anasiru, SKM, M.Kes.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Good morning, Honorable Secretary Director General of Health Professional of Ministry of Health, Honorable invited speaker, respected chairwoman of the Indonesian Midwife Association of Gorontalo Health Polytechnic, Health Organizing Committee, distinguished participants, dear colleagues, ladies and gentlemen. It gives me immense pleasure in welcoming all you to the session, the second International Conference on Midwifery and Health Science 2022. Optimizing midwifery services to prevent non-communicable disease in reproductive cycle. On behalf of Gorontalo Health Polytechnic, I would express my gratitude to all invited speakers, Dr. Nisha Clement, Dr. Maria Cristina Ramajo, Ribeka Horiguchi, Dr. Tjokorda, Gede Dalem Pemayun, spesialis penyakit dalam, KEMD Finasim, and Dr. Nurjasmi, M.Kes. Thank you for accepting our invitation and sharing your remarkable research. Moreover, to the organizing committee, thank you for your effort to arrange this conference. As it is known that the first international conference on midwifery and health science 2021 had been successfully held with more than 1,000 participants and 47 published articles. Those are proof of your considerable effort. On behalf of my institution, I am completed to all the research scholars and paper presenters from various parts and country who have met in the conference. These papers were enlightening all of you present here on the importance of midwifery roles in preventing non-communicable disease during a reproductive cycle. I believe that by participating in conference, you are in the right place and the right time. Together, let us accelerate the exchange of ideas and scaling of good particles. In this special occasion, I wish you all the best and hope you enjoy the ideas and expertise exchange. Thank you all for present and participant. It is privilege for the Gorontalo Health Polytechnic to host you all in this conference. I sincerely hope you all will enjoy the next 2-day discussion and networking. Thank you. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Thank you, Mr. Muhammad Anas Anasir.
We are now continuing our meeting to the next agenda, that is to hear the keynote speech, which will be delivered by Director General of Health Workers, Ministry of Health of the Republic of Indonesia, each represented by Secretary Directorate General of Health Workers. Ladies and gentlemen, please welcome Mr. Sugianto SKM MSCPH.
Thank you. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Good morning, everyone. It's actually this morning is very grateful for me to follow this international forum. It is a good agenda, and for this season, I would like to apologize from my Directorate General Health Workforce because she not been joined for this forum because other agenda. Honorable guest speaker, I hear from India, from Philippines, from Japan, and also our colleague, Mr. Dr. Tjokorda, and another speaker, and also all of the participants. Basically, appreciate for me to head Polytechnic of Gorontalo to this forum, especially international forum, because this is one of the effort of the how to head Polytechnic implemented the science forum. Apologies for this session. I would like to speak in Bahasa, and again I would like to convey this keynote speech. Assalamualaikum warahmatullahi wabarakatuh. Yang saya hormati Direktur Politeknik Kementerian Kesehatan Gorontalo beserta jajaran, para narasumber, Bapak Ibu hadirin peserta internasional conference yang berbahagia. Pertama-tama marilah kita panjatkan puji dan syukur kehadirat Allah SWT. Pada pagi hari ini kita bisa berkumpul dalam kondisi yang sehat, bertatap muka secara virtual dalam agenda the Second International Conference on Midwifery and Health Science 2022 di Poltekkes Kemenkes Gorontalo ini. Saya menyampaikan apresiasi kepada direktur dan jajarannya atas terselenggaranya kegiatan ini. Semoga kita dapat mengambil sebesar-besarnya manfaat dari pertemuan ini. Hadirin yang saya hormati. Next slide. Kita ketahui saat ini pola penyakit di Indonesia telah bergeser menjadi penyakit yang bersifat katastrofik yang berpotensi akan meningkatkan beban dan menurunkan produktivitas manusia di masa mendatang. Target RPJMN 2020-2024 pada sektor kesehatan telah menitikberatkan pada peningkatan upaya cakupan, penguatan pelayanan primer, promotif preventif, serta inovasi dan pemanfaatan teknologi. Hal ini sejalan dengan target Indonesia Emas 2045 untuk menjamin ketersediaan, keterjangkauan, kualitas, serta kewaspadaan bagi masyarakat. upaya pencapaian target RPJMN di bidang kesehatan tahun 2020-2024 berfokus pada 5 target besar, yaitu pertama, meningkatkan kesehatan ibu, anak, keluarga berencana, dan kesehatan reproduksi. Kedua, mempercepat perbaikan gizi masyarakat. Ketiga, meningkatkan pengendalian penyakit. Keempat, gerakan masyarakat hidup sehat atau germas. Dan yang kelima, memperkuat sistem kesehatan dan pengendalian obat dan makanan. Keterlaksanaan RPJMN tersebut harus dapat tergambar dengan indikator target yang jelas dan terukur. Kementerian Kesehatan telah menetapkan indikator target yang mendukung keterlaksanaan sistem kesehatan termasuk pelayanan kesehatan secara komprehensif. Indikator target tersebut telah tertuang dalam Peraturan Presiden Nomor 18 Tahun 2020 tentang Rencana Pembangunan Jangka Menengah Nasional atau RPJMN tahun 2020 sampai 2024 yang kemudian dipertegas dalam kebijakan turunannya, yaitu reformasi sistem kesehatan nasional. Dalam RPJMN 2020 sampai 2024 dan reformasi SKN tersebut terdapat 3 target yang berkenaan dengan pemenuhan SDM kesehatan di fasilitas kesehatan, yaitu puskesmas tanpa dokter, pemenuhan 9 jenis tenaga kesehatan di puskesmas, dan pemenuhan 7 jenis dokter spesialis pada RSUD kabupaten kota. Next slide. Stunting adalah kondisi gagal tumbuh pada anak berusia di bawah 5 tahun akibat kekurangan gizi kronis dan infeksi berulang, terutama pada periode 1000 hari pertama kehidupan, yaitu dari janin hingga anak berusia 23 bulan. Anak tergolong stunting apabila panjang atau tinggi badannya berada di bawah -2 standar deviasi panjang atau tinggi anak seumurnya. Stunting menjadi topik yang menarik perhatian banyak pihak dalam beberapa tahun belakangan. Stunting dan gizi buruk atau wasting disebutkan sebagai 2 dari 4 persoalan gizi yang dihadapi anak Indonesia. Berdasarkan hasil riset kesehatan dasar tahun 2018, sebanyak 30,8% atau sekitar 9 juta anak Indonesia mengalami stunting. Jumlah ini melampaui standar maksimal dari Organisasi Kesehatan Dunia atau WHO, yakni sebesar 20% atau 1/5 dari jumlah total anak balita dalam suatu negara. Untuk itu, target pada tahun 2024 menurun menjadi 14%. Penyebab dari stunting adalah rendahnya asupan gizi pada 1000 hari pertama kehidupan, yakni sejak janin hingga bayi umur 2 tahun. Selain itu, buruknya fasilitas sanitasi, minimnya akses air bersih, dan kurangnya kebersihan lingkungan juga menjadi penyebab stunting. Stunting dapat dicegah antara lain melalui pemenuhan kebutuhan gizi bagi ibu hamil, pemberian ASI eksklusif selama 6 bulan, kemudian dilanjutkan dengan MPASI. Orang tua juga diharapkan membawa balitanya secara rutin ke posyandu, memenuhi kebutuhan air bersih, meningkatkan fasilitas sanitasi, serta menjaga kebersihan lingkungan. Periode ini telah dibuktikan secara ilmiah merupakan periode yang menentukan kualitas kehidupan. Oleh karena itu, periode ini ada yang menyebutnya sebagai periode emas, periode kritis, dan Bank Dunia menyebutnya sebagai window of opportunity. Prevalensi stunting di Indonesia mencapai 27,7%, termasuk tinggi. Angka ini juga melebihi batas prevalensi WHO 20%. Sementara prevalensi wasting dan overweight 7,% dan 5% termasuk sedang. Jika dibandingkan dengan negara-negara ASEAN lainnya, prevalensi stunting Indonesia cukup tinggi, urutan keempat tertinggi di bawah Laos, Kamboja, dan Filipina. Di Indonesia, stunting adalah kondisi gagal tumbuh pada anak berusia di bawah 5 tahun akibat kekurangan gizi kronis dan infeksi berulang, terutama pada periode 1 hari pertama kehidupan, yaitu dari janin hingga anak berusia 23 bulan. Anak tergolong stunting apabila panjang atau tinggi badannya berada di bawah -2 standar deviasi panjang atau tinggi anak seumur. Next slide. Faktor-faktor yang pendorong penurunan stunting adalah status kesehatan dan gizi ibu, anak, dan edukasi gizi. Faktor-faktor tersebut menyebabkan rata penurunan prevalensi per tahun di tingkat global sekitar 2,2%. Rekomendasi WHO menyampaikan bahwa berdasarkan policy brief, pertama adalah meningkatkan deteksi dini, pengukuran dan pemahaman stunting, serta memperluas cakupan kegiatan pencegahan stunting. Yang kedua, implementasi kebijakan dan atau memperkuat intervensi untuk meningkatkan kesehatan dan gizi ibu, mulai dari remaja putri. Yang ketiga adalah implementasi intervensi untuk meningkatkan cakupan ASI eksklusif dan makanan pendamping ASI. Yang keempat adalah penguatan intervensi berbasis masyarakat, termasuk meningkatkan cakupan akses air bersih dan sanitasi untuk melindungi anak-anak dari penyakit infeksi, yaitu diare, kecacingan, malaria yang disebabkan oleh lingkungan yang tidak sehat. Next slide. Hadirin yang berbahagia, pada kurun waktu 3 tahun, sistem kesehatan dunia tidak terkecuali Indonesia mengalami masalah kesehatan yang luar biasa dengan adanya pandemi COVID-19 yang mengakibatkan krisis multidimensi, ancaman pelemahan ekonomi yang merupakan imbas dari pandemi COVID-19, membuat negara-negara di dunia harus menunda realisasi rencana-rencana strategis yang telah ditetapkan dan digantikan dengan kebijakan tanggap darurat dengan memobilisasi semua sumber daya untuk mengatasi wabah termasuk SDM kesehatan. Belajar dari pandemi, Kementerian Kesehatan berupaya melakukan transformasi sistem kesehatan yang memprioritaskan program promotif, preventif, dan kegiatan preventif ini dilaksanakan di seluruh kehidupan masyarakat. Saat ini Kementerian Kesehatan tengah fokus pada penguatan ketahanan sistem kesehatan dan akselerasi perwujudan target RPJMN 2020 sampai 2024 sebagai upaya mengendalikan pandemi dan bentuk antisipasi terhadap kondisi luar biasa pandemi yang mungkin akan terjadi di masa mendatang. Transformasi sistem kesehatan ditempuh dengan memperkuat aktivitas promotif preventif, menciptakan lebih banyak orang sehat, memperbanyak screening kesehatan, serta meningkatkan kapasitas layanan primer. Kemudian yang kedua, transformasi layanan rujukan dengan meningkatkan kualitas dan pemerataan layanan kesehatan di seluruh pelosok Indonesia. Ketiga, memastikan ketahanan kesehatan, sistem ketahanan yang baik di tengah ancaman kesehatan global. Ini mencakup produksi hingga distribusi farmalkes yang lancar dan bisa diproduksi dalam negeri. Keempat, transformasi sistem pembiayaan kesehatan dengan kemudahan dan kesetaraan akses layanan kesehatan bagi masyarakat yang kurang mampu. Kelima adalah transformasi SDM kesehatan dengan memastikan distribusi tenaga kesehatan merata di seluruh pelosok tanah air, termasuk di kawasan DTPK. Dan yang keenam adalah transformasi teknologi kesehatan, baik berkaitan dengan pemanfaatan teknologi informasi dan bioteknologi di sektor kesehatan. Melalui perbaikan dan penguatan tersebut, transformasi sistem kesehatan mampu meningkatkan layanan kesehatan yang nantinya dapat berimplikasi pada peningkatan derajat kesehatan masyarakat yang setinggi-tingginya. Next slide. Pilar pertama yaitu transformasi layanan primer. Dengan harapan semua orang memiliki akses yang mudah ke layanan primer, seperti imunisasi, konsultasi dokter umum, pemeriksaan kesehatan, dan edukasi masyarakat yang mengenai pola hidup sehat. Next slide. Program utama penguatan upaya preventif di layanan primer diantaranya adalah pemberian imunisasi BCG, DPT, HIV, hepatitis B, MMR atau MR, polio, TT atau DT dan juga TD, CE, HPV, PCV dan juga rotavirus. Kemudian juga screening penyakit penyebab kematian tertinggi di setiap sasaran usia. Kemudian melakukan pemantauan tumbuh kembang anak di posyandu dengan alat antropometri terstandar dan pemeriksaan kehamilan atau ANC dari 4 kali menjadi 6 kali termasuk 2 kali USG dengan dokter pada trimester 1 dan 3. Next slide. Kementerian Kesehatan sedang melakukan transformasi struktur kelembagaan layanan primer hingga ke tingkat desa dan dusun untuk memperluas jangkauan. Saat ini sedang direncanakan program Posyandu Prima atau Lembaga Kemasyarakatan Desa per Desa, diintegrasi dari Pustu dan juga Poskesdes, di mana pada Posyandu Prima ini minimal ada 2 tenaga kesehatan, yaitu 1 bidan dan 1 perawat. Kemudian juga memiliki sarana prasarana standar untuk menyediakan layanan dan peran sebagai LKD kesehatan. Ini dilakukan untuk mendukung peran kader sebagai aktivis kesehatan di komunitas dan diharapkan ada 5 kader per dusun atau RT atau RW. Next. Untuk pilar SDM kesehatan. Pilar SDM kesehatan dengan jumlah yang cukup, merata, dan berkualitas di seluruh Indonesia. Next slide. Gambaran sebaran provinsi dengan kebutuhan 9 jenis tenaga kesehatan dapat dilihat dalam tabel di bawah ini. Ini menunjukkan bahwa dari 34 provinsi, sebenarnya Gorontalo memiliki 92 puskesmas. Dan kebutuhan bidan hampir terpenuhi di seluruh puskesmas di Gorontalo. Ini saya kira menunjukkan kita sudah memberikan tersediaan khususnya bidan sudah sangat mencukupi, yang notabene-nya ini harus tetap dipertahankan. Next slide. Program unggulan transformasi SDM kesehatan meliputi terkait dengan penyediaan tenaga kesehatan. Dalam penyediaan tenaga kesehatan ini, penambahan prodi spesialis 9 penyakit prioritas, seperti anestesi, bedah, dan jantung, termasuk di Fakultas Kedokteran swasta. Implementasi academic health system untuk memperbanyak wahana pendidikan kesehatan di M.Kes, dengan melakukan pemberian 10.000 lebih beasiswa hingga tahun 2024. Yang kedua adalah pendayagunaan tenaga kesehatan. Kemudahan regulasi diaspora kesehatan WNI lulusan luar negeri untuk mendukung ketersediaan tenaga kesehatan, pendayagunaan tenaga kesehatan WNA sebagai bagian dari intervensi dari investasi pengabdian tenaga kesehatan yang dibiayai pendidikannya sesuai lokus rekomendasi Kementerian Kesehatan. Rekrutmen calon ASN dalam bentuk PNS atau P3K pada institusi kesehatan yang ada di puskesmas, rumah sakit, laboratorium kesehatan, dan lain-lain sesuai lokus rekomendasi Kementerian Kesehatan. Dan yang ketiga adalah peningkatan mutu tenaga kesehatan yang meliputi beasiswa fellowship untuk peningkatan kompetensi spesialis tenaga kesehatan dan pelatihan kesehatan dalam rangka meningkatkan dan memanfaatkan kompetensi transfer ilmu dan teknologi diaspora dengan nakes, puskesmas, dan rumah sakit pemerintah. Next slide. Pelayanan kebidanan perlu mendukung program kesehatan yang komprehensif untuk mengatasi permasalahan kesehatan ibu dan anak dengan output pertama adalah penurunan kesakitan, kematian ibu dan bayi. Yang kedua adalah peningkatan kualitas hidup ibu dan bayi. Yang ketiga adalah penurunan pembiayaan kesehatan. Dan yang keempat adalah peningkatan kesejahteraan keluarga. Program kesehatan yang komprehensif meliputi upaya promotif dan pengobatan yang dimulai sejak wanita remaja atau wanita usia subur, ibu hamil, ibu bersalin, dan ibu menyusui, bayi baru lahir, bayi dan anak di bawah 2 tahun. Mengapa berfokus pada bayi dan balita? Karena adanya tren kenaikan angka stunting dari bayi baru lahir ke bayi dan balita. Next slide. Untuk melakukan tersebut perlu dilakukan strategi. Strategi yang dilakukan meliputi pertama adalah peningkatan kapasitas SDM. Yang kedua adalah peningkatan kualitas program, dan yang ketiga penguatan edukasi gizi, serta yang keempat melalui penguatan manajemen interview gizi di puskesmas dan posyandu. Intervensi gizi meliputi percepatan penurunan stunting remaja dan 1000 hari pertama kehidupan. Pertama adalah promosi dan konseling pemberian makanan bayi dan anak. Kemudian pemantauan pertumbuhan dan perkembangan balita. Ketiga, suplementasi gizi mikro yang meliputi tablet tambah darah ibu hamil dan remaja, vitamin A balita, dan ibu nifas. Keempat adalah penanganan masalah gizi dengan pemberian makanan tambahan. Next slide. Kemudian apa peran dan fungsi bidan itu sendiri? Dalam menyelenggarakan praktek kebidanan, bidan dapat peran sebagai pemberi pelayanan kebidanan, pengelola pelayanan kebidanan, penyuluh dan konselor, pendidik, pembimbing, dan fasilitator klinik, penggerak peran serta masyarakat dan pemberdayaan perempuan, serta sebagai peneliti. Adapun fungsi bidan diantaranya pertama adalah melakukan bimbingan dan penyuluhan kepada individu, keluarga, serta masyarakat, khususnya kaum remaja pada masa pra-perkawinan. Kedua adalah mengembangkan konsep kegiatan pelayanan kebidanan bagi individu, keluarga, kelompok masyarakat sesuai dengan kondisi dan kebutuhan masyarakat setempat yang didukung oleh partisipasi masyarakat. Yang ketiga adalah memberi penyuluhan kepada individu, keluarga, dan kelompok masyarakat terkait dengan pelayanan kebidanan dalam lingkup kesehatan, serta keluarga berencana. Keempat adalah melakukan evaluasi, pengkajian, survei, dan penelitian yang dilakukan sendiri atau berkelompok dalam lingkup pelayanan kebidanan. Dan yang kelima adalah melakukan penelitian keluarga dan keluarga berencana. Next slide. Tentunya harapan kepada bidan ada beberapa hal yang harus diperhatikan. Pertama adalah dalam manajemen kasus kebidanan, bidan berkolaborasi dengan klien, teman sejawat, bidan, dan tenaga kesehatan lain. Kemudian bidan memahami sistem pelayanan terintegrasi dengan fokus kebutuhan klien dalam manajemen kasus dan juga terkait dengan kegiatan pelaksanaan kebidanan itu sendiri. Kemudian mengembangkan pelayanan dasar kesehatan di tempat kerja, berpartisipasi dalam tim untuk melaksanakan program kesehatan, kemudian melakukan penelitian sesuai jenjang pendidikan yang diperoleh, dan menjadi tenaga pendidik yang selalu meningkat pengetahuannya. Hal tersebut dapat dilakukan dengan baik, tentunya dengan adanya dukungan yang kuat dari seluruh stakeholder. Next slide. Demikian Bapak Ibu yang dapat kami sampaikan. Terima kasih. Semoga apa yang dilakukan dalam kegiatan yang baik ini akan betul-betul bermanfaat. Terima kasih. Saya akhiri. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you, Mr. Sugianto. For the success of this morning activity, let's listen to the prayer that will be read by Mrs. Nur Inaya Adam, SST.
Assalamualaikum warahmatullahi wabarakatuh. Good morning, ladies and gentlemen. Let us bow our head for a moment, pray to God Allah Subhanahu wa Ta'ala, so that our international conferences can be precious to all of us. I will lead this prayer based on the teaching of Islam, and those who are not Muslims, you are pleased to pray according to each of your beliefs. Bismillahirrahmanirrahim. Alhamdulillahi Rabbil Alamin. Hamdan yu'afi ni'mahu wa yukafi'u mazidah. Ya Rabbana lakal hamdu kama yanbaghi li jalali wajhikal karim wa azimi sultanik. Allahumma inna nas'aluka salamatan fid din wa afiyatan fil jasad wa ziyadatan fil ilmi wa barakatan fil rizqi wa taubatan qabla al maut wa rahmatan indal maut wa maghfiratan ba'dal maut. Allahumma ghfir lana wa liwalidayna wa lil muslimina wal muslimat wal mu'minina wal mu'minat al-ahya'i minhum wal amwat innaka sami'un qaribun mujibud da'wat ya qadiyal hajat. Oh Allah, from 22 until 23 July 2022, we gather here to bring about the second international conferences on midwifery and health science. The theme is optimizing midwifery services to prevent non-communicable diseases in the reproductive cycle. Make this international conference as a useful science assembly, as a medium of sharing useful ideas, knowledge, and experiences of scholars, researchers, and students of various disciplines. May the conference we organize today benefit to our lives, broaden our knowledge, shine our ideas, and lead us to be successful, productive person, which in turn will boost dignity of our nation. O Allah, guide and bless our hearts and our minds with the light of your guidance. Impart your supreme wisdom, open our activities. Help us to speak our minds clearly. Help us to listen to each other, respect each other, love each other, so that we are included to the blessed persons. O Allah, protect us from unintended temptation, show us the right path, and give us knowledge and strength to perform good things equally, show us and make it clear the bad things, and give us knowledge and strength to avoid them. O Allah, you are the one who can fulfill our dua. Rabbana atina fid dunya hasanah wa fil akhirati hasanah wa qina adzaban nar. Subhana rabbika rabbil izzati amma yasifun wassalamun alal mursalin walhamdulillahi rabbil alamin. Amin amin ya rabbal alamin. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you, Mrs. Nur Inaya Adam.
Playing song of Mothers of the Gorontalo Health Polytechnic.
Pendidikan profesional, ini rangka
to inform you that the event was held in collaboration with the Department of Midwifery Gorontalo Health Polytechnic in collaboration with the Alumni Association of Midwifery of the Gorontalo Health Polytechnic ICABIT-GO, Indonesia Midwife Association of Gorontalo Health Polytechnic, Bank Syariah Indonesia Gorontalo, BSG, Bank BNI, Kimia Pharma, Fituno, Hotel Aston Gorontalo, Hotel Grand Key Gorontalo, Hotel Damhil Gorontalo, Lembaga Pelatihan Cendekia Indonesia Training Center, Laboratorium Klinik Prodia, Health, Klinik Radix Dental Care, and many sponsors. On behalf of the committee, we would like to thank you for this good cooperation and support.
And now we will hold a photo session. All participants who have not activated the camera are requested to activate the camera. The committee was asked to take a photo session. We will start from session 1. Next, session 2. Session 3. Next, session 4. Next. Okay, the last, session 6. Okay, thank you.
I represent the committee ICMS 2022. Give thanks for Vice Director 1, 2, and 3 in Gorontalo Health Polytechnic, Chairman of Indonesia Midwife Association of Gorontalo Province or represented Mrs. Olan Yusuf SST, Chairman of Indonesia Midwife Association of Gorontalo City, Mrs. Ervina Hassania SKM M.Kes, Chairman of ICABIT-GO, Mrs. Yuyun Gunibala AMD CAP, and the invite guys on arrival in opening ceremony of ICMS 2022. Ladies and gentlemen, with the end of the whole series of opening events this morning, let us close by reading Hamdalah. Alhamdulillahirabbil alamin. Wassalamualaikum warahmatullahi wabarakatuh. Thank you.
Waalaikumsalam warahmatullahi wabarakatuh.
And now, we are now continuing our meeting to the next agenda, that is plenary ones, that is to hear the first speakers, which will be delivered by Ribeka Horiguchi, Associate from Otemae University, Japan. The first speaker will be moderated by Yesrafil Esfam, MBiomed, and the theme is the first speakers is the current situation of maternal mental health in Japan. Hello, Mr. Israfil. Are you active in camera? Mr. Israfil, this is your time. Thank you.
Okay, right. Yeah. Hello, is my voice sounds clear?
Yes.
Right.
Yes,
Yeah.
very clear.
Okay, right. I'll start it. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Start this event, I'd like to say good morning, everyone. Good morning, Mrs. Ribeka Horiguchi in Japan time.
Good morning.
Okay, right. Nice to meet you all and in this great event. And I think this is a great chance for me to moderate and receive the amazing insight in our lineup today. And first of all, I'd like to say thank you very much for inviting me to be a moderator for the first speaker in this great event, the second international conference on midwifery and health sciences. I'm Israfil from Faculty of Medicine, University of Palangkaraya. Today, we have a good lineup, and firstly, I'd like to say hello, Mrs. Ribeka. Good morning in Japan time, and nice to meet you, Mrs. Ribeka.
Nice meeting you too.
Yeah, even it comes by virtually, but I hope we could get many insights from you today. And I also send warm regard to academic staff of Health Polytechnic of Gorontalo, especially to Mr. Anas Anasiru as director, Mrs. Rabia Zakaria as head of Department of Midwifery, and Dr. Candidate Zulfiayu as my supervisor and head of Department of Pharmacy. And let's go to the webinar. Here with us, Mrs. Ribeka Horiguchi as the first speaker. She will share to us about the most current issue in the worldwide. It is about mental health issue. With the title topic is current situation of maternal mental health in Japan. As we know, mental health issue is the most common talking about topic today, especially for maternal, both in pre and after of birth as well. And together, we will listen to a presentation about maternal mental health, what is the current condition, and how the impact is. And absolutely, all of us are very curious about the presentation from Mrs. Ribeka, and it's the same thing that I feel today. But before I send my microphone to Mrs. Ribeka, let me to briefly introduce our speaker today, right? Yeah, please, his full name is Associate Ribeka Horiguchi, Bachelor of Science, Master of Science. She was born and live in Japan. Currently, she is lecturer in Fundamental Nursing course in Otemae University, Japan. Her Bachelor of Science of Nursing were obtained from Keio University in 2007. Her Master of Degree in Global Health were obtained from King's College London 2017. Ribeka Horiguchi have some work experience, including nurse midwife, public health nurse, midwife, Japan Overseas Cooperation volunteer as nurse, and midwife, and nurse, sorry. And Mrs. Ribeka Horiguchi have 3 licenses in Japan as a nurse, as midwife, and as public health nurse. And that's the briefly introduce about our speaker today. And now I'll invite Mrs. Ribeka Horiguchi to deliver her presentation. And for Mrs. Ribeka Horiguchi, time is yours.
Hi. So, can I share my presentation now, right?
Yes, yes. You can screen your presentation.
Thank you for your kind, very kind and warmful.
Yeah.
Can you see the can you see the slides?
Yes, we can see.
Okay, and can you hear me well? Hello?
Hello, yeah.
You can hear me well?
Yes, yes. We can hear you well.
So now we can start.
Okay, right.
Sorry.
Please.
Before start my presentation, I really feel sorry of my poor English. So if you have something, any questions, or to make it clear, please interrupt me anytime, and feel free to ask me. Thank you.
Okay, right.
So about today's topic, you already know, and I will cut my introduction to. And today's topic I would like to share with you is maternal mental issues, and also I would like to introducing postpartum care in Japan through case study. And finally, I would like to summarize the maternal care in Japan through my governmental policy. And if we can have a discussion, what kind of care or idea can you adapt in your country setting? And in the end, we would like to have a question and answer. About today's goal, to be able to describe major maternal mental issue in Japan, and to be able to describe futures of maternal care in Japan, and also to be able to discover the difference between Indonesia and Japan in terms of maternal care, and to be able to discover better ideas of maternal care in Indonesia. Is it clear for everybody?
Yes, it's clear.
So I would like to talk about the first topic. Before I introduce the situation of maternal mental health, I would like to show the overview of maternal health in Japan. And this graph is provided by the Association of Obstetricians and Gynecologists in Japan, and they are continuously conducting maternal death review, and this is the latest result. Their death review is predicted, the reported ones, the death which reported to the association were examined. So maybe not all. And the graph shows 50%, 57% of maternal death are related to direct obstetric cause, and 24% of indirect obstetric death. In total, there is around 80% of maternal death related to the medical issues. And I hope there is still some solution for those medical issues. However, in Japan, the condition of obstetric treatment has been improved a lot, And you also know that there are occasions of death which we cannot avoid. So today, as I am the midwife and not a doctor, I wonder why we cannot save these 5% of suicide. Can you clearly see the gray one?
Okay, right. We can see.
So this research is for the maternal death, I mean during pregnancy and within 40 days after the birth. And can you imagine the situation 1 month later after meeting your cute, sweet newborn baby? You ended up your life. Why should these Japanese mothers have to choose the options of suicide? And also, I wonder, is it true that we as midwives couldn't do anything for those mothers or pregnant women? And it is really sad news, but actually there is another report which mentioned that there may be around 30% of mothers suicide. So from this graph, if you focus on maternal death, I mean pregnancy and within 42 days after birth, there is only 12% of maternal suicide. But the number becomes more than the double from the previous research. And if duration was set within a year of after birth, the suicide becomes 28.6%. And this research was revealed and recognized mother death through registration of live birth and death certificates. Actually, the trend of these suicides are mothers who are over 35 years old, and there is no one who has a job in her family. In addition, there is a trend that no specific timing for mothers to die. The suicides occurred during pregnancy and after birth continuously until the first birthday of her baby. So additionally, I would like to introduce this research too. Do you know the MMR in Japan?
Oh, MMR.
Yeah, if anyone knows, if somebody knows MMR in Japan.
MMR like polio or measles?
Pardon?
Polio or measles?
Sorry, I don't understand.
Okay, right.
Anyway, do you know the MMR in Indonesia, right?
Right, yeah, right.
Mortality rate. So could you please teach me?
Okay, maybe you can continue the presentation.
Okay, sorry. Actually, MMR in Japan, we are successfully reducing MMR, and since 2013, the MMR in Japan is around 3, only 3, and this number is provided by Japanese government. And even the World Bank data shows 5 since 2012. And actually, I found the data in Indonesia, but the data was only 2017, and it shows 177. So you may understand, but I'm talking about the maternal death related to medical issues. It's really hard for us to reduce dramatically from the number of MMR3. So let's go back the slide. And although MMR in Tokyo is 3.9 during the research period, there is unknown death among mothers, and it is called maternal suicide. The ratio is more than the double comparing to the MMR in Tokyo. You can see the 8.7, and in the research, half of these mothers who ended up by suicide, they had psychiatric disorders such as postpartum depression and schizophrenia. Furthermore, there is child death, baby death by abuse. The double death means mothers and babies both dead. And among the 71 deaths, 27 was dead with their mothers. Among the 44 deaths, over half of these babies were killed by their mothers. And among the 27 deaths, 15 babies were killed on the day when they were birthed. The risk factors of this child abuse are mainly known as unmarried, adolescent, and unwanted or unintended pregnancy. The mother's motivation for killing a child is mainly rejection or denial of their babies. On the other hand, mental disease such as anxiety for raising a child, feelings of burden are motivations of double death. From this research, we can see that the depression can impact on maternal suicide. For during pregnancy, around 40% of mothers' suicide was combined with mental illness. After the delivery, the situation becomes worse. 60% of mothers who committed suicide was diagnosed as depression. Maternal depression, especially postpartum period, is really a big issue in Japan. So this is the research of prevalence of maternal depression, and I hope you remember the trend of maternal suicide. Actually, mothers over 35 years old and primipara and no income, and also there was specific period for mothers to kill themselves until the first day of their baby's birthday. So you can see the data that around 15% of prevalence of maternal depression during pregnant period and postpartum period, especially for the first month. And after the first month until the year, around 11% of prevalence was shown. And also, primipara is significantly higher prevalence than the multiparas. So the trend seems similar to the maternal suicide, and I don't think that there is no relationship with the trend between maternal suicide and maternal depression. So here, I wrote the risk factors of maternal depression. During the pregnancy, anxiety and life events, medical history of mental disease, and less various support, domestic violence, and intended or unwanted pregnancy become risk factors. Also, about the postpartum period, medical history of mental disease, anxiety or depression during pregnancy, less various support, domestic violence, and also experience of child abuse for mothers and unintended or unwanted pregnancy can be risk factors. And I guess that you can easily imagine anxiety, medical history of mental illness, domestic violence, unintended or unwanted pregnancy as triggers of maternal depression. But can you imagine what the lack of support means? I don't know, but in Indonesia, there are many mothers who are suffering from lack of support to raising babies. I hope no. So why Japanese mothers are enduring such pain by themselves? Why they can't talk and relieve their anxiety with their family or with their friends? Why they cannot get any advice from their mothers or friends how to raise their babies? Why they cannot get any help so that they can sleep and rest? The clues are here. You may know that Japan is called as super-aged society, and our life expectancy is over 87 for women and 81 for men in 2019. Also, the healthy life expectancy is around 75 for women and 72 for men in 2016. And also about the family structure, in Japan, major family structure becomes nuclear family. And we don't usually live together with our parents. I would like to explain a little bit more why mothers cannot get enough support from their family. If you see the graph, you can see the age of mothers. Even for the first childbirth, the average mother's age is over 30. I want to emphasize that this is the average number. In the field, I worked as a midwife until 2 years ago, but if you see the mothers in this age of 30, we said they are young. In addition, please guess the age of mother's parents. I would like to give you an example of me. I have a 2 years old and 4 years old girls, and I become 40 years old in this April, and my mother also becomes 70 years old. So in Japan, if someone is 30 years old to have a child, baby, and their parents usually are in 50s to 70s, mostly over 60s is common. Actually, it is really hard for grandparents who are over 60s to help mothers and babies physically. And on the other hand, you may say they are not all over 60s. And yes, it is true. There are some younger grandparents too. But do you think that they can help mothers and babies if mothers' parents are in the age of 50s? Actually, if they are 50s, they are still working regularly. In Japan, around the age of 60s is the retirement timing. Recently, it becomes later, and usually people are retiring in age of 65. So if someone has regular job, it is really hard for her to help mother and the babies. And especially if they don't live together with their parents. Because of the distance, the difficulty becomes severe. So about the structure of Japanese household, from this graph, among the households with children, over 80% of households are nuclear family. Only 13% families are living together with their grandparents in 2019. If you live far from your parents' house, especially because of the COVID pandemic, the situation gets worse. Mobility limitations are still remaining. Even there is no official bans, most mothers who have newborn babies avoid traveling. Therefore, the isolation for mothers becomes severe now than even a few years ago. In addition, I want you to show the awareness about pregnancy and childbearing in Japan. This report is distributed in 2011. So about 10 years ago, over 30% of mothers claimed they feel they are isolated from the society. If the society is not tolerant to children, can mothers go out? Actually, it is really hard to decide to go out with babies or little kids who cannot behave well. If they choose staying in a house, she has to hear babies cry 24 hours, and no one talk to her verbally. If you live far from your hometown and your parents, you may not have any friends, neither any relatives whom you can talk to comfortably. What I want to say is, mother needs help physically, but also emotionally. And there are mothers who cannot get both. I wonder the recent situation in Japan, because this research was reported in 2011, and I cannot imagine how much % of mothers can feel like them because of the COVID pandemic. So after the sad news, let me introduce what kind of care we are providing. How long do mothers stay in a hospital? This is really congratulations timing. In Japan, after birth, mothers usually stay for 4 to 5 days if they have normal spontaneous vaginal delivery. For cesarean section, 7 to 9 days. What do you think about this period? Is it too long or too short? Or the same as in Indonesia? Day 0, we as a midwife usually let mothers sleep in order to take enough rest. And this is a meal. I had tempura. Can you see the picture? This is traditional Japanese food. And rice, soup, vegetables, also dessert. From the day to day 4, there are some trainings and lectures, including family planning and danger signs of mothers and babies are told to them, like the timing of them to come back hospital, such as bleeding, fever, abdominal pain, and so on. And also, of course, we are practicing breastfeeding or amusing a baby or bathing a baby. So what kind of bathtub do you usually use for babies? What you see in the picture is for in a clinical setting. And this is a newest style of bed for babies. So day 5 for vaginal delivery and day 7 for C-section. This is the day of discharge. After mother gets enough knowledge and skills, baby can meet all family members. Maybe the mom feels so happy on the day of discharge, but she doesn't know what kind of life starts from today. Please see the timetable. I made an example of daily schedule. And this mother has two children. So I made this timetable, and if you can think how long can she sleep and when can she sleep? I want to ask to the audience, but is it difficult, right? Okay. So let's continue my slide. But actually, she cannot sleep at all. Even there is a 4 hours timing, but actually people cannot sleep for 4 hours. I mean, there are some disturbing, and if mother cannot sleep well, in Japan, we can see these mothers usually. So no mother can smile. If that kind of life continued in Indonesia, I wonder how every mother manages the life right after their delivery. And we started to have the second week checkup regularly since maybe around 5 years ago. And this checkup focused on mothers. However, midwife normally provide the checkup for babies, and they usually come back after a week of their discharge. The contents of checkups are vital signs, weight, and sometimes urine, and EPDS. Do you know what is EPDS? I hope. And this is a screening test for detecting postpartum depression. If you find, can you hear me? Okay.
Yes, we can hear me.
Okay.
We can hear you. Sorry.
So if you find a case of high risk, we usually ask for continuous help to public health nurse to follow her. But I heard that in Indonesia, you don't have any public health nurse. So I guess midwives are doing the same job. And in Japan, these are the topics which public health nurse handling. And I don't know if Indonesia do you usually do the home visit, but in Japan, public health nurses and midwives are doing home visit. So now I would like to show you one website which is very informative for foreign mothers. And I also would like to introduce the one YouTube video which shows the home visit to mother and child. Can you see the website?
Yes, you can see, Mr.
Yes. So this is made by Kanagawa International Foundation, and they made very informative website for foreign mothers. And from this website, if you are interested in, please later. And I would like to show you one YouTube video. Sadly, I couldn't find in Indonesian version. So today, I would like to show you the English version.
ここは住まい探し中の人が迷い込むスーモの森。こんにちは。
Can you see the video?
Yes, we can see, Mrs.
Okay, so I continue the
母子訪問について。こんにちは、ナンディソッカです。日本では赤ちゃんが生まれた後に赤ちゃんとお母さん向けのサービスがあるのを知っていますか？ 今日は母子訪問についてお話しします。母子訪問は赤ちゃんが生まれてから役所の方が自宅に来てくれるものです。料金は無料です。保健師さんや助産師さんなどが赤ちゃんとお母さんの様子を確認します。ちょうど私の友達エソダさんのところに赤ちゃんが生まれました。エソダさんのところの訪問を覗いてみましょう。まず訪問の前に役所から電話があり、訪問の日と時間を決めます。日本語がわからない場合はそのことを伝えておきましょう。神奈川の人で日本語ができなくて伝えられないときは多言語ナビ神奈川に相談しましょう。そして決めた日の約束の時間に保健師さんまたは助産師さんがやってきます。母子手帳を見せられるように用意しておいてくださいね。訪問する人は挨拶の後、手をきれいにします。これは赤ちゃんに外からの菌を持ち込まないためです。そして今日の訪問でどのようなことをするかの説明をしてくれます。この訪問では赤ちゃんの様子、お母さんの体調の確認、そして困っていることがあれば相談に乗ってくれます。また今後の子育ての情報をもらいます。さあ一つ一つを見ていきましょう。1、赤ちゃんの様子。まずは赤ちゃんの様子を確認します。赤ちゃんを乾いたおむつ1枚にして体重、頭の周り、胸の周りなどを測ります。今回測った赤ちゃんの記録は母子手帳に書いていきます。そして赤ちゃんの様子について質問があります。例えば赤ちゃんが毎日どのくらい母乳、ミルクを飲んでいるか、赤ちゃんのうんちがどんな色かなどです。赤ちゃんの様子で気になることがあったら伝えてください。2、お母さんの体調。次はお母さんの体調も確認します。赤ちゃんを産んだ後に体がちゃんと戻っているか、赤ちゃんのお世話で疲れていないか、子育てを手伝ってくれる人がいるのかなどです。3、相談。子育てについて不安や悩みがあれば必ず伝えておきましょう。例えば赤ちゃんが夜寝てくれないので体がとても疲れているなど具体的に伝えるのがいいと思います。自分の国ではどんな子育てをしているかも知らせると良いですね。4、情報。赤ちゃんの予防接種のこと、役所で受ける乳幼児検診のことなどが確認できます。また近くの小児科や保育園、子どもが突然夜中に熱を出した時などに行ける病院を確認しておきましょう。子育てに関していろいろな多言語情報も案内してくれます。もし情報がない場合はこちらのホームページを確認してみてください。地域によってはその他の訪問もあります。この訪問員は民生委員さんなどの地域に住む方です。親子が住んでいる地域で楽しく子育てするためにも顔を覚えて情報をもらいましょう。訪問を終えたエソダさんに感想を聞いてみましょう。エソダさん、今日の訪問はいかがでしたか？
はい、とっても安心ですね。特に、外国に住んでいるので、相談に乗れる人とかあまりいないので、こういうふうに家に来てくれて、その家の環境だったり子どもの健康だったり、いろんなことを教えてくれますので、また その病院とかですね、近くの病院とか予防接種のことを、または子どもが成長していて保育園に入るまでのことを教えてくださるので、とても安心です。で、私は今、産後のお手伝いで、国からお母さんが来てるんですけれども、母が来てるんですけれども、特にこうそのお母さんが帰った後にとか、ここに一人で住んだ時にどういう困った時にご相談に乗ってくれる人がいるっていうことはとても安心ですね。もう電話して相談に乗ることとか、お伺いして話もできるということはすごく安心だなというふうに思いました。
これから日本で赤ちゃんを産む外国人のお母さんへメッセージをください。
そうですね、外国で子供を産むっていうことはとても不安だと思います。で、やはりその初めて子供を産むっていうことはいろんなことわからないと思いますね。子供が泣いたらなぜ泣いたのかとか、そういうことはわからないと思うんですけれども、こういう訪問があったらいろんなこと聞けますので、気にせずぜひ受けてくださいっていうふうに皆さんに伝えたいと思います。
母子訪問のこと分かりましたか？私の国にはこういった訪問がないので、最初に訪問があると聞いたとき、役所の人が来て何をするのか不安でした。でも日本で子育てをする最初の一歩の段階でこのように親切にしてもらえると安心ですね。
So I hope everybody could see the video. And
Okay.
I go back to my slide. Do you have this kind of home visit in Indonesia too? I hope yes, but I also hope that you could see the real example of Japanese home visit.
Okay, right.
And after that, usually after the home visit, public health nurse usually assess the mother's situation, and if her EPDS is high, she's at risk of postpartum depression, and she can't sleep because of managing everything, and she didn't have any support. And based on these problems, public health nurse can make the care planning. Public health nurse can plan the care for the mother. And these are the example of care plan and follow-up home visit for a few months by midwives or public health nurse. And also postpartum care, we call it tango care in the midwifery clinic. This is for the purpose of sleep and rest, and also practicing how to raise her baby. And also get support from the community paid volunteers. We have governmental community paid volunteers, and they can help for mothers as cleaning the house or laundry and cooking and shopping too. So Sango care, postpartum care in the midwifery clinic, usually mother can stay in the midwifery clinic for 7 days maximum. And this duration, they can get financial aid from the government. And they can take a rest, as I told you, and they can ask training for midwives whatever they need, midwife usually provide for her. And these are the website of other types of midwifery clinic.
Okay.
I hope you can, it's too small. I hope you can see the mood of midwifery clinic by the governmental one, and also other type. Sorry. This is the Association of Midwifery Clinic in Osaka, and like private room and lecture room by tatami with here the ground. And this is also, we call it salon, and mothers can have a chat here. By the way, can you see the website which I am showing?
Yes, we can see, Mrs. Ribeka.
Okay.
Yeah.
So 1 month later, we usually have a 1 month checkup in the hospital. So this case, she becomes really okay. And for me, it is really important early detection and early intervention. And it's also important that don't let them feel isolated or lonely. Of course, we do the physical checkup for this time, but by midwife, we also check the mental status too continuously. And here, I would summarize the maternal care in Japan. There are key points, 4 key points I would like to talk about. And the first one is comprehensive counter for mothers and children, and also have close cooperation between various sectors. These are the example of sectors: community health centers and hospitals, midwifery clinics, and nursery, kinder, school too, and welfare sectors, also security from the police officers. And these 2 key points mean that if the mother needs help, she should go to the one office, and from that office, the officer, usually public health nurse, calls other sectors to contact her or to help her. Sometimes even she needs to go to the other offices. However, at least she doesn't need to talk from the very first why she is there. And this is also what I made. And from this diagram, I would like to introduce the way we are coordinating with various sectors. EHN in the Comprehensive Support Center uses formatted letters or direct calls to communicate with teachers, police, and other department of officers, and also hospital, clinic, and midwifery clinic. And PHN usually do the health checkups or direct call, interviews, and home visit to follow up the mothers. But in order to identify the problems, registration for live birth or mother and child book, or formatted letter or formatted postcard in the mother and the child book are used. And mother can visit, and mainly, as I told you, public health nurse coordinate with others since they are the best profession in Japan that can understand various aspects such as mothers to children and physically and mentally, and of course, individually and socially. So these are the two other keys: uninterrupted support from birth to adulthood. And this, we are monitoring families through kids or babies, especially before entering the school. Mainly public health nurse is the main coordinator, as I told you before. And from the pregnancy, collaborating with hospitals, they monitor mothers. After is it okay for me to continue?
Yes, sorry, our system is distract. Okay, you can.
Okay.
You can continue. Okay.
So after she has a baby, a mother has a baby, public health nurse collaborates pediatricians, nurseries, or kinder, and also they conduct governmental health checkup for babies until 4 years old regularly. And after that, checkup is conducted in the elementary school around 5 to 6 years old as pre-entering checkups. And therefore, every child is monitored by someone regularly in Japan. Actual duration can be every 2 to 3 months for babies, and after that, maybe we can say 4 to 6 months, or sometimes 6 months to 1 year for kids because of vaccinations and regular health checkups. The last one I put here is two-way communication. I want to tell you that even the mother doesn't think she needs help. If the health professions assess the needs of her, mostly public health nurse can contact the mother in order to provide what she needs. Of course, there are cases that the mother rejects those help, but for the safety of her children, we have a responsibility to monitor her children's health condition. And also, I would like to show you a video again.
Hello, greetings from Colombia. My name is John London.
Hello, my name is Julia.
Can you see the video?
Yes, we can see Mrs. Ribeka.
Okay, so
外国人住民のための子育てチャート。 妊娠・出産から小学校入学まで。こんにちは。私の名前はナンディソッカです。今、私のお腹に赤ちゃんがいます。日本に住む外国人が安心して子育てをするために、この子育てチャートで紹介していきます。ステップ1、ママになるための準備。妊娠から出産までの流れや手続きを確認しましょう。あなたの国の制度や習慣と違うことがいろいろあるけど、日本での流れを覚えておくと安心ですよ。赤ちゃんは一般的に産科のある病院などで産みます。妊娠の早い時期に分娩予約をしないといっぱいになってしまうので、早めに病院に行きましょう。通訳が頼める病院もあります。病院で母子手帳をもらってきてと言われるので、次に行くのは役所です。母子手帳はあなたの住んでいるところの役所で受け取ります。一緒に妊婦健診の補助券ももらえるので、病院で健診に行くときは必ず両方持って行ってくださいね。外国語版を用意している役所もあるので、窓口で聞いてみましょう。補助券はこんな感じ。自治体によって金額は違います。妊娠中の検診は定期的にあるので、必ず毎回受診するのが大切です。妊婦検診では栄養や体重管理など指導があるんです。母国のやり方とは違う場合もありますが、ちゃんと聞いてくださいね。私も太りすぎて注意されちゃった。日本で赤ちゃんを産むには平均50万円かかります。健康保険に入っている場合は支払いの一部がカバーされるので、生まれる前に病院で手続きしてくださいね。私の場合は50万円だったので、健康保険の出産一時金からこのぐらい。自分ではこのぐらいを払ったのよ。病院や役所で行われる母親学級や両親学級では出産や育児について学べます。夫も張り切って参加してるけど、もう緊張して大変だったわ。出産するとき、病院に約5日入院します。入院に必要なものは事前に確認しましょう。また、産気づいたときに病院へ行く方法も調べておきましょう。私の友達のエソダさんも出産前に病院からのリストを見て、入院に必要なものを揃えていきました。産気づいた時に慌てないように早めに準備しましょう。そして私、ついに赤ちゃんを産んだんです。日本では今30人に1人が外国につながる赤ちゃんなんだそうです。さて、これから日本での子育てが始まります。どんなことが待っているのか楽しみだわ。ステップ2、生まれてからすること。赤ちゃんが生まれてすぐにやらなければならない手続きがあります。見ていきましょう。うちでは夫がやってくれました。赤ちゃんが生まれたら14日以内に役所に出生届を提出します。役所でできる手続きは一度にやっておくといいですよ。他にも役所でできる手続きは、 小児医療費助成。これを申請すると赤ちゃんが無料で病院にかかることができるんです。国民健康保険の場合は保険証は一緒に申し込めるんですよ。それから児童手当の手続きと出生連絡表。詳しいことは窓口で確認してくださいね。お友達のジギャンさんが役所で手続きした様子はこちら。たくさんの窓口で手続きをしていますね。そうそう、忘れちゃいけないのが次に行く入管手続き用の出生届受理証明書と赤ちゃんを含めた住民票など、役所で取っておいてくださいね。さて、役所の次は大使館と入国管理局。大使館の情報は自分で確認してね。入国管理局は赤ちゃんの在留資格を申請します。この手続きは生まれてから30日以内にしなければいけません。それぞれの手続きには締め切りがあるから気をつけてね。さてさて、これでようやく手続きが終わって一安心だわ。ステップ3、赤ちゃんとママの健康のために。赤ちゃんが生まれた後、子供とお母さんの健康を定期的に確認します。病院、自宅、役所といろいろな場所で検診があるので、その都度確認してくださいね。赤ちゃんが生まれてから1ヶ月経つと、出産した病院で1ヶ月検診があります。ここでは赤ちゃんの発育や健康、お母さんの体の回復などを確認します。その後、自宅に役所の保健師さんや助産師さんが訪問してくれます。赤ちゃんの様子、私たちママの体調や困っていることを聞いてくれます。この訪問については別の動画で詳しく説明しているので確認してみてくださいね。この頃、役所からの手紙も増えるのできちんとチェックしましょう。生後2ヶ月頃から予防接種を受け始めます。役所から配布される予診票にあるワクチンは無料で受けられます。決められたスケジュールで受けましょう。決められた時期を過ぎるとお金がかかるので注意してください。受ける場所は基本的に小児科です。近所のかかりつけ医を決め、夜間、休日診療所も確認しておきましょう。役所から乳幼児検診の案内がありますので、必ず受診してくださいね。場所は役所で受ける場合と病院で受ける場合があるので確認してください。これらの検診は無料で受けられます。検診では育児で困っていることの相談もできますよ。ステップ4、お家から地域への初めの一歩。生まれてから小学校に入るまでに住んでいる地域とつながっていると安心ですよ。子育て支援センターを知っていますか？住んでいる地域で学校に入る前の子どもと保護者同士が交流したり、子育て相談ができる場所です。赤ちゃんが小さいうちから一緒に行けるから安心だわ。出産後、保護者が仕事をする場合などは保育園に子どもを預けることができます。 認可保育園の場合は役所で申請します。早めに相談しましょう。利用料は所得によって変わります。また、小学校入学前まで教育を受けるところとして幼稚園があります。小学校に入る前に日本社会や集団生活に慣れることができます。自治体によっては教育・保育を合わせて行う認定こども園もあります。情報は役所で確認してくださいね。外国籍の子どもがいる家庭には、小学校入学前の秋頃に公立小学校の就学案内が送られてきます。教育委員会、役所などで入学申請をしてください。日本国籍の場合はこの手続きはいりません。小学校の就学通知が送られてきます。入学前の健康診断や説明会には必ず出席してくださいね。小学校に入る前に準備するものがたくさんあるので、何が必要か、どこで買えるかなど、小学校の先生に聞きましょう。私の息子も無事小学校に入学しました。皆さん、妊娠・出産から小学校入学までのステップ、理解できましたか？日本で長く暮らしていく上でも、小学校までの6年間にいろいろなサービスとつながっていれば、とっても安心ですよ。外国語で相談できる窓口もあるので、その時々でわからないことは確認してくださいね。ほら、こんなにたくさんの外国につながる子どもたちが小学校に入学しているわ。
This is a really digest of our welfare system and the registration and also the health system for babies and kids. So I hope you could see the real image of comprehensive counters and also the real example of cares in Japan.
Okay, that's great. That's show great example in Japan.
Thank you for your kind comments. And so now let's go back to the slide. And can you see the slide or not yet? No.
Oh,
not yet, right?
Not yet, not yet. Okay, right.
So here, okay. If you are interested in my country's governmental policies, if you research about the healthy parents and the children 21, that they have a digest of English version, and if you have time, please check it too.
Wow, exactly.
Also, this diagram is provided by the policy. There is the monitoring cycle, which shows by orange color, and there is a blue cycle, which shows cooperation. And you can see that the actual care is provided by various sectors, even including companies or NPOs. But the monitoring system is established by the government, and they are continuously finding out the main issues among children with their family. So also this is the illustration from the policy, and key major one, we emphasize that we are here for mothers, and this is very important. We try delivering the message to all mothers, and we hope all mothers don't feel lonely because they have babies. And key measure 2, we have to detect the risk of child abuse as early as possible. I mean that even before babies are born. This is important in order to prevent the death of 15. Do you remember that the baby died on the day of their birthday? And fundamental measure 8, health professions try watching over mothers and babies continuously. Fundamental measure B, the support has to be provided even their school age. And also fundamental measure C, creating child-friendly society. And also you remember that how many mothers claimed that they had the experience of feeling isolated or public apathy from the graph. And from my presentation, I hope that you could understand why these key measures and fundamental measures are important for us in Japan. So last topic, what kind of care or ideas can you adapt in your setting? Maybe together with the question and answer, do we still have time?
Yes. You can continue the presentation. We have still time.
Okay, but in this last topic, I need your cooperation. And if you have any ideas, and could you please ask to the audience, including question and answers?
Right.
Actually, I don't know the detail of situation in Indonesia, but I heard that you also have major family structure as the nuclear family. And also, I don't believe that your society is not the same situation in Japan, but maybe because of the economic status is improved, maybe the families recently more moved into the city than living in a countryside. And from that situation, I guess that the society has changed. And maybe you also, I don't know, I only guess, but do you really, I really only guessing, but in Indonesia, do you have any unrecognized maternal death or like maternal suicide?
Yes, of course.
I see. Do you have any procedures for avoiding that?
Yeah, for avoiding, maybe it the same measure that Japan conduct. there are some measure to avoid the maternal suicide or maternal depression.
Okay. And do you usually use EPDS for screening the maternal depression?
Yes, we have adopted the EPDS, Edinburgh Postnatal Depression, in Indonesia too.
Okay. So maybe there wasn't a new idea or idea from my presentation, but I hope that you could understand the situation in Japan, and I hope you all think about the prevention or solution for maternal suicide in order not to become the severe situation in your country.
Okay, maybe you can explain about in Japan. But because in Indonesia, I don't know the detail of the measure, because I'm a pharmacist. Of course, yeah. Yeah, maybe you can continue the slide.
Okay. So I hope I could have an interactive speech or active conversation with the audience too.
Okay, right. Maybe in question in session of Q&A.
Okay. So this is the last slide. There might be unrecognized deaths in your country too, and I really hope if the social background has changed, please, for the midwives too, please pay attention to various issues in order to avoid the ignorance and unfocused maternal death. Thank you very much.
Okay, Mrs. Ribeka, yeah, that's great presentation, and we would like to extend appreciation for your presentation. From the presentation, I highlight some important subject in your slide, including in fact that you presented the third semester and second semester period become the higher risk to get maternal depression in pregnant period. And furthermore, mother at the first month of postpartum period, sorry, I have problem with my device. Okay, right. I'm sorry. I have problem with my device. Okay, right. Okay, I continue. As you presented, in fact, that you presented the third semester and the second semester period become the higher risk to get maternal depression, of course, in pregnant period. And furthermore, at the first month and of postpartum period have higher possibility to have maternal depression. It's so confused fact. I also noted that primipara have significantly higher prevalence than multipara to get some maternal depression. And in another explanation, we have noted some maternal risk factor to depression, including anxiety that have you presented, and lack of support as most important issue, and then experience of child abuse. This is very most common in Indonesia about the experience of child abuse currently. And how the impact is, as you presented, the impact of maternal depression is can lead aging of society. I think that's very clear that when birth is lower, it could lead aging of society. And the second impact is nuclear family structure. And I guess supportive measure as the most common measure for us to mother during period for to avoid or prevent maternal depression. And I guess we should check ADPS in continuously to assess that maternal health, maternal mental health is normal condition. And that great insight for us as a candidate of husband, mother that preparing maternal pregnancy or other. And that's new knowledge for me from pharmacists. And thank you very much, Mrs. Ribeka. And I have not some question. Some question have been put out in chat box. Please, committee, can it show in screen for the list of question? And let me to read one by one to further answer by Mrs. Ribeka. Okay, right. Is the screen is clear, Mrs. Ribeka?
Yes, yes.
Okay. Okay, the first question from Nisrina from Polkesmar. I want to ask, in Japan, does mental disorder in postpartum mother cause suicidal ideation and throw away their children and what service have been done by midwife for the treatment or for this treatment of the problem? Maybe you can answer for the first question.
Yes, actually, we have mothers who already have mental disease or mental disorders. And we, as a public health nurse, if we detect the mothers who has mental disorders when they come to the comprehensive office to get maternal and mother and the child book. And after that, we have collaboration with this clinic where she gets treatment, also where she gets checkup for her pregnant situation. So if something happened, if the collaboration is well done, we can recognize before mother threw away their children. So we can do something for those children. So for those mothers, the worst case that she cannot raise her baby at all, then we will get a baby from her, or if her family member, like husband or her parents, cannot take over in order to raising this baby, then its government office is the one who will raise those children. So as midwife, we have to do close cooperation with public health nurse and give information of the mother's status. And before the mother becomes serious situation, we try to protect the mother and the children both. Is it clear for this? Is my answer is clear for this question?
Okay, that's clear, Mrs. Ribeka. That's great.
We as a midwife, we cannot do for the treatment, medication or something like that. So monitoring and giving information to the office which we have to contact. That is a responsibility for us.
Okay, right. That's great response from Mrs. Ribeka. I think that's clear for the first question. And yeah, it's clear, Mrs. Ribeka?
Yes, yes.
Yes. Okay, we continue with the second question from Mustafa from Poltekkes Kemenkes Semarang. The question is, miscarriage can leave a sense of trauma. Not only can this be stressful, this sad event can also cause some symptom and anxiety and depression or post-traumatic stress disorder or PTSD, and some health worker don't realize it. The question is, what program or effort have been made by the health department or one of hospital in Japan to treat post-traumatic stress disorder in post-miscarriage mother, and are they able to restore their reproductive health to normal?
And the situation in Japan, maybe we can say it, how can I say, it depends on the midwives. Really, they don't care about the miscarriage, but most of, I'm not sure for this question, but through my experience, I don't think that there is a official treatment or official training for post-miscarriage mothers, and maybe I have to research a little bit more.
Okay.
In Japan, but I can say that in the educational status, I mean, to educate the midwife, we are including those cases, and we are focusing on the cases for the we cannot say exactly PTSD. However, there is an effect on the mental health for women after a miscarriage. So we are teaching of that. And
okay.
Actually, we have an abortion. So miscarriage also have a problem.
Okay.
To women's mental health, but also we also have abortion problems for those women, and through my experience, after abortion, maybe bigger issue in Japan. Many women has stress or mistreated after getting abortion.
Okay. Right. Okay. I note some highlight from your answer. The measure to treat PTSD is training and education to mother that have been miscarried. Is it true, Mrs. Ribeka?
Yeah, no, and actually, I wanted to tell you that there is no training or for midwife how to treat those mothers, and also
Okay.
there is clear treatment for mothers in an aspect of mental health after miscarriage.
Maybe
So,
the question is what treatment for it? What type of treatment for it? Maybe you can give one example for us.
About the PTSD, right? In post-miscarriage mothers. I mean, I don't think midwives are providing those treatment in the hospital.
Okay.
Maybe in a community setting, peer chat, peer education, or like chatting other mothers who had miscarriage, and that can relieve their feelings. However, we don't have official treatment for those mothers.
Okay.
Is it clear?
Okay, is it clear? Very clear.
However, I wanted to tell you, through the education of midwifery, we are trying to teach them that there are some mental effect on mothers who had miscarriage.
Okay.
Okay, and also I don't know about the Indonesian situation, but we have abortion. So rather than miscarriage, women who had abortion had bigger mental stress usually.
Okay. Okay, right. Okay. Maybe that's very clear for the second question. And then next question, I would like to remind to all of participants who want to ask question, you can raise your hand and ask directly to Mrs. Ribeka, or type your question in chat box. Okay. How the committee? There are any question? Okay, in raise hand, there are two raise hand. Maybe you can ask your question directly to Mrs. Ribeka. Mrs. Nanda Wahyudi raise hand. You can ask your question to directly to Mrs. Ribeka. Mrs. Nanda. Mrs. Nanda, is my voice is clear? Okay. The other person, Citra Puspita Putri is raise hand. Or Sri Uli Yafni. Okay, maybe from the committee, could you please to share the question in screen? Hello. Hello. Committee. How about my voice? Is it clear? Okay, maybe I'd like to read the question from chat box, Mrs. Ribeka. Yeah, of course. The question from
excuse me?
Yeah.
I want Assalamualaikum warahmatullahi wabarakatuh.
Okay. Waalaikumsalam warahmatullah.
My name is Ribeka from Poltekkes Gorontalo. I want to ask about what is the impact on pregnant women who have mental disorders. Thank you.
Okay, could you replay your question? Maybe it's not clear. Hello. Could you please to repeat your question? Hello. Okay, Mrs. Ribeka, is your clearly heard, listen the question, or?
I'm sorry.
Okay, right.
Okay.
Please.
What is the impact on pregnant women who have mental disorders?
Okay, is it clear, Mrs. Ribeka?
Yes. Thank you.
Okay, right. Please. What the impact of?
Impact of pregnant women who has mental disorders. Actually, they cannot raise their babies properly. They cannot they cannot make their checkup regularly. If they feel tired, especially if they have a depression, once they feel very tired or something difficult to go out from the house, then they keep their checkups. That makes their babies in danger. And also, if they combine with the hypertension and so on, they cannot have a properly to medicate their health issues. And also, they put their babies in a danger situation. Even after they have a baby, they cannot properly give milk for their babies, or sometimes they I don't want to say, but they hit their babies or they ignore the babies and so on.
Okay.
So it's really have a big issue for the depressed women to have to raise a child.
Okay, right. Okay. How about the answer, Mrs. Labacho? Is it clear? Yeah, I think that's clear. That's very clear from Mrs. Ribeka. And then let's get to the next question. Yeah, there are some raised hand from our participant. Okay, Mr. Arif, maybe you can ask the question from.
Assalamualaikum.
Mr. Arif?
Yes.
Hello? The voice is not clear.
Hello? Can you hear me?
Okay, right. Please.
Hello?
Hello?
Okay, right.
Okay. Okay. Good morning, Miss Ribeka. My name is Nanda Wahyudi. I'm from Poltekkes Gorontalo. Miss Ribeka, I'm very interested with your presentation, especially regarding maternal suicide in Japan. Because maternal suicide in Japan is something new for me. In Indonesia, I almost never hear about the incident of maternal suicide. But in Japan, it has a high number. Miss Ribeka, I want to ask you about this maternal suicide. What is the Japanese government program to reduce the incidence of maternal suicide? Maybe ongoing. Beside home visit for mother and child program from Kanagawa University, we watch a video. Okay. Maybe like providing psychology to assist to every mother during pregnancy to postpartum with a free cost. Thank you, Miss Ribeka.
Right. Is it clear, Mr.
Yes.
Mrs. Ribeka? Mrs. Ribeka?
I understand your question like this, that
Okay.
what we are doing for mothers in order to reduce maternal suicide in a government section, right?
Yes, right.
Is it okay, Miss?
Okay.
Mrs. Nanda, is it right?
Yes, right, Miss Ribeka.
Okay. Actually, we, as I told you before, we started to have a second week checkup after their delivery. That is a big issue for us. That is a big improvement for our system. And before, I guess 5 years ago, we didn't have a second week checkup. And after mother and the child discharged from the hospital, they go back to the hospital 1 month later. And in 1 month later, we usually see the situation of a baby in low weight, and the mother has already depression. And that's why we started to have the second week checkup. It means second week after birth, so usually 1 week later of their discharge. Is it clear?
Okay, Miss Ribeka, can I ask you something?
No.
Who is do that program? Midwife, nurse, psychologist, or doctor?
Actually, the second week checkup is provided only by midwives.
Okay.
And
with a free cost or have
free cost usually.
Free cost.
Free.
Okay. What is
So,
the name of program in Japan about that?
Could you please ask me again?
What the name of program? That program that have you explained? Maybe
in Japanese.
Yes. In Japanese or in English? Maybe in Japanese.
We call it Nishukan Kenshin in Japanese.
Okay.
And that means second week checkup.
Okay.
Is it okay? And can I add one more thing? Yes. During this second week checkup, we have to do EPDS, Edinburgh Postpartum Depression Scale, for all mothers.
Oh, it's the same thing with EPDS.
Yes, I already.
Okay, right. Oh, right.
So that is our measure to prevent the maternal suicide.
Oh.
The first month of period after their delivery.
Also to assess the maternal mental health, right?
Yes.
Okay, right.
These days, for every mother in our whole country, it is conducted. So that is a big screening occasion for us.
Okay, okay. Right.
Is it clear?
Yes,
Miss?
it's so interesting. And thank you, Miss Ribeka.
Okay, I think that's finished for the first speaker. Time is finished, and that's the final question and answer from the first section, and what a great sharing from Mrs. Ribeka to extend the appreciation.
Sorry.
Okay.
Can I ask one?
Okay, right. Please. Okay, right, please. For the last question.
Introduce myself. My name is Citra Puspita Putri, and I want to ask Mrs. Ribeka, and I want to ask, we know that pregnant women after giving birth often experience the baby blues, and then now what I want to ask is, can the baby blues be cured with medication?
Can you repeat again?
Can you repeat your question, Ms. Citra? Hello, Ms. Citra?
Yes.
Can you repeat your question?
Yes. Yeah.
Okay. Right.
The
Please.
pregnant woman. We know the pregnant woman after giving birth often experience the baby blues, and now I want to ask that, can the baby blues be cured with medication?
Is the depression can be treated by drugs? Is right? Is it right?
Yes.
By consumption of drug. Okay. The question is the core of question is the baby blues or maternal health depression can cure by or treat by drug? That's the question, Mrs. Ribeka.
Okay. Could you explain about the baby blues?
Baby blues, maybe is it the same case as depression after
like maternity blue.
Yeah, maternal. Yeah.
Okay. The question is it able to
treat with drug
by the medication?
Yeah.
There is a treatment. There is a medication, and some mothers who can get medication, but not only the medication. Maybe we have to combine support for them to take a rest or support for them emotionally. That is important. Not only by the medication is treated. Is it
okay? Is it clear, Mrs. Citra? Hello. Is it clear?
Yes, thank you.
Okay. Right. Okay, I think time has finished for the first section, for the first speaker, and that's the final question and answer in this section. And what a great sharing from Mrs. Ribeka. And to extend appreciation for your presentation, we will give you a certificate of appreciation as the speaker of this conference. And here we serve Mrs. Ribeka.
Yes.
Okay, can we take documentation? The committee, please.
Sorry, I couldn't hear well.
We would like to documentation with the giving of certificate.
Yes.
Okay, please, committee. Okay, finished. So thank you very much, Mrs. Ribeka, for your presentation today and for your knowledge, sharing knowledge today. Thank you very much. See you next time.
Thank you very much.
Yeah. Bye-bye.
Bye.
Okay, right. MC, I'd like to send the voice to MC.
Thank you, Mr. Israfil, and thank you, Mrs. Ribeka Horiguchi. And now for our questionnaires in the plenary session 1 to Mrs. Rina from Polkes Semarang, Mrs. Musrofa from Polkes Semarang, and the last Mrs. Sri Ulfiani Labajo from Polkes Politeknik Kesehatan Gorontalo will get the interesting prize from Committee ICMHS 2022. So the questionnaires is Mrs. Melisawati Amu will contact our questionnaires. Thank you. And now we would like to invite the second speakers to be able to convey extraordinary knowledge delivered by Mrs. Dr. Maria Cristina Ramajo from Arellano University, Filipina, with the theme Health Education in Women in Relation to Pregnancy. The second speaker will be moderated by Mr. Muhammad Arif Ismail, SPD MA Tesol. So, Mr. Muhammad Arif, it's your time. Thank you.
Okay. Can anyone hear me okay? Dr. Maria, can you hear me okay?
Yeah. Can you hear me too?
Yep, sounds really good.
Okay. Good.
Right, let me just get started. So, just firstly, good morning, ladies and gentlemen. Welcome again to the second plenary speaker of the second International Conference on Midwifery and Health Sciences 2022. My name is Arif, and I'm your moderator for this second plenary session. Just before we get into the presentation, allow me to briefly introduce you to our second speaker today, Dr. Maria Cristina Ramajo. I hope I pronounced your name correctly. From Arellano University, Philippines. Dr. Maria Cristina has been really involved in the area of midwifery, particularly in school context, association, and its curriculum making. She holds a degree in midwifery and nursing, acquired from a college called Mary Childs in Manila. In 2009, she completed her master's study in nursing in Philippines Women University. Then she went to Arellano University and eventually acquired a doctor in education back in 2016. Dr. Maria Ramajo has received both Loyalty and a Leadership Award during her study. Her recent international collaboration with Indonesia addressed breastfeeding in the time of pandemic, March 2021. All right, ladies and gentlemen, I would like to invite Dr. Maria Cristina Ramajo to deliver her presentation. Over to you, Dr. Ramajo.
Hey, good morning, everyone. I'm very, very pleased to be part of these endeavors. To the organizers, to all the university officials, I thank you very much for including me in the list of speakers. I am very humble enough and honored to be part of this very prestigious webinar. Okay, so for my presentation, as is being mentioned, it is about health education for pregnant women. Sir, will you share my slides? Okay. Will you do sharing my slides, please?
Yeah, the committee is doing that.
Okay. Okay, so while waiting, I'm very happy to see your beautiful and handsome faces again. I'm happy to be with you again and hoping in the future I'll be visiting your country again. Okay. Before the pandemic, we've been there in Semarang, okay, and in other cities of Indonesia. And I'm very happy because all the people in Indonesia are very accommodating, very hospitable, Okay, and I have been in different places in your country. It's beautiful. Your country is beautiful. Even the people are there. You are so very hospitable with regards to your visitors. Okay, so I'm very happy again to be part of this. And sooner we can see each other face to face. Okay, so okay.
Yeah, that sounds really good. We would be really happy to welcome you again in our beloved country. Just want to confirm, are you going to share your own screen by yourself, or do you want us to share your screen?
Kindly share it,
okay,
please.
We'll do that.
Share it. Okay, thank you.
Okay, share screen. I'll do that. This one. Right. So I'm taking control of your screen. Let me know.
Okay. Thank you, sir. Okay. So to start with, my title is about health education in women in relation to pregnancy. Okay. Next slide, please, sir.
Yeah.
Okay. So for the introduction, the World Health Organization, or WHO, envisioned a world where every pregnancy or pregnant women and newborn receives quality care throughout the pregnancy and childbirth and the postnatal period. 303,000 women and adolescent girls died as a result of pregnancy and childbirth-related complications in 2015. 99% of maternal deaths occur in low-resource setting, and most can be prevented through education. 2.6 million babies were stillborn in 2015 because of lack of education for their mothers. During the antenatal period, you can promote the health of the women in the health of their babies before and after birth by educating mothers the benefits of good nutrition, adequate rest, good hygiene, family planning, and exclusive breastfeeding, and immunization and other disease prevention. Okay, so this is it. So, okay, so the goal of WHO is to lower morbidity and mortality in pregnancy as well as in newborn. Okay, so the objectives of my presentation is to describe the major dietary constituents for good health in pregnant women and advise women on eating well with little money and explain the problems resulting from a poor diet, which affects the outcome of their pregnancy. Explain the benefits of good hygiene and other self-care activities in pregnancy. Explain the benefits of immunization against tetanus, and explain the benefits of early and exclusive breastfeeding for mothers as well as for her baby. And last, explain the benefits of family planning to achieve birth spacing and discuss postpartum contraception with pregnant women. Okay, those are the topics in my presentation. Let us define antenatal care. Antenatal care is the systematic supervision, examination, and advice of a woman during pregnancy. It's an antenatal or prenatal care. The pregnancy is 9 months, and it is divided into 3 trimesters. Each trimester has 3 months. So there is so much preparation while being pregnant because pregnancy in human occurs for 9 months. Okay. So what is the aim of antenatal care? Is to achieve at the end of the pregnancy a healthy mother and a healthy baby. This care can begin soon after conception and of course throughout pregnancy and after pregnancy. Okay, so you can see here in the picture, every mother in the community is invited in the health center, in the medical facility or hospital to register. So once a woman misses her menstruation and expect that she is pregnant, okay, she must consult, okay, or to register. If the pregnancy is positive, so, okay, she will seek, okay, prenatal care, okay. That's it. Next slide, please. Registration. To register themselves at the nearest health facilities as soon as pregnancy is detected, there are 4 antenatal checkups, which is essential for a pregnant woman. First, antenatal checkup, as soon as the period is missed or within first 3 months of missing the period. So yung first trimester, that is very, very important, okay? Because during the first trimester, the organogenesis is being developed, okay? The organs of the fetus is being developed on the first 3 months of pregnancy. So this is very crucial that the mother should consult. And for the second antenatal checkup on the 4th and 6th months of pregnancy, wherein the fetus is now fully developed. So guidance to the mother with regards to the nutrition, hygiene, and everything should be given to the mother on the second antenatal checkup, as well as in monitoring the progress of the development of the fetus. Third antenatal checkup is during the 7th and 8th month of pregnancy, wherein delivery is coming near. Okay. Now, for the last, the 4th, checkup on the 9th month. Okay. This will entail weekly checkup for the mother. Okay. So, every week, the mother should report to the obstetrician or the medical doctor who attends to the mother. So regular antenatal checkup visits protect the mother and the baby from complications and ensures a healthy mother and child. Because nowadays, every pregnancy is being considered as high risk because of our lifestyles. Okay, now, what includes in the antenatal checkup? First and foremost, the mother, the vital signs of the mother will be taken, such as the temperature, most particularly the blood pressure. Okay, and then followed by the height and the weight, because the height and the weight entails if the mother is at high risk. Okay, if the mother is below 5 feet, they consider it high risk pregnancy. Why? Because of the cephalopelvic disproportion that may occur during labor and delivery. Okay, and for the height, for the weight, if the mother is overweight, it may lead to gestational diabetes. Okay, so we also regulate the weight of the mother during pregnancy. Okay, and of course the laboratory exam, complete blood count, which includes the red blood cells count, the white blood cells, okay, and everything, and of course Hep B screening if the mother is positive for Hep B screening. So during delivery, the newborn will be given 2 kinds of immunization, so to address, okay, the Hep B being acquired from the mother. And of course, HIV screening, which is done here in the Philippines, it is a mandatory screening. All pregnant mothers should undergo HIV screening for AIDS. Okay, and of course for urinalysis, if there is a urinary tract infection, because UTI may also lead to infection to the fetus inside the utero. Okay, then ultrasound, okay, to know the position, the actual age of the fetus inside the utero, okay, and when to deliver the baby. Okay, the fetal heart tone and the Pundik height. Okay, the fetal heart tone reveals, okay, if the fetus inside the utero is functioning well, has good heartbeat, okay, is thriving, okay, and the Pundik height, whether the fetus is gaining weight, okay, because there is actually here in the Philippines, we're expecting normal weight for infant or newborn is from 7 pounds and below. Okay, above 7 pounds, that is all already macrosomic for us. Okay, and it's really very difficult for the mother to deliver big babies, 8 pounds, 9 pounds. Those are big babies already, and it almost leads to cesarean section. Okay, Leopold's maneuver, it is being done to know the presentation. Okay, the normal presentation is usually cephalic, meaning the head is being on the cervical os. Okay, and of course the age of gestation, how old is the fetus? Okay, normally 38 weeks, 38 weeks is the preterm. It is below 38 weeks. Okay, 38 to 40 weeks is preterm. So below 30, 37 or 38 weeks, we call that preterm by age. Okay, if it is above 40 weeks, it is already above the term mix, so that is post-term already. And for the expected date of confinement, this is very important. So the mother knows when to deliver, so they can prepare everything. Okay, they will have their plans, so we'll bring the mother to the hospital. So we also educate the mother, the companion, her companion of choice, the things to be brought to the lying-in clinic or in the hospital. Okay, because here in the Philippines, we discourage home delivery here in the Philippines. We encourage all women to deliver in the facility, like lying-in clinics, accredited by the Department of Health, and of course the hospital. Okay, next slide please. Okay, so you can see in the picture, okay, the midwife is getting the blood pressure of the pregnant mother, as well as checking of the abdomen of the mother, using the Leopold's maneuver 1, 2, 3. Okay, so for Leopold's 1, what occupies the fundus, and Leopold's 2, what occupies the side of the utero, and of course what occupies the lower uterine segment. And of course we inform the mother about this one. Okay, so if there is a breech presentation, we inform the mother. Okay, we educate the mother what to do. Okay, so if it is on the 7th month, maybe the fetus inside the utero will change the position before being given birth. Okay, next slide please. Okay, nutrition. Let's talk about nutrition. This is very important. Okay, nutrition during pregnancy. It is written here, eating well. What do we mean by eating well? Eating well means having all the 3 food groups, the GO, GROW, and GLOW foods. Okay, it is not necessarily that you buy expensive ingredients, okay, for the pregnant mother. Okay, those